Hello, everyone, and welcome to today's webinar on people who are incarcerated. My name is Michelle Woods, and I am the Program Director for Homeland Security at the National Governors Association. Today's webinar is hosted by the National Governors Association in collaboration with the American Bar Association. It concludes a four-part webinar series on equity and policy preparedness during public health emergencies. Previous webinars have focused on how responders can ensure equity and policy preparedness in the encouragement and enforcement of mitigation measures, distribution and uptake of remedies and resources, and people experiencing homelessness. This work is funded by a cooperative agreement between the NGA and U.S. Centers for Disease Control and Prevention. The presentation does not necessarily represent the views of the NGA or the CDC, and the information presented should not be construed as legal advice or guidance. My colleague Jeffrey Locke will now provide an overview of NGA's work in this area.
Great. Thanks, Michelle. Good afternoon and good morning, everyone. We know folks are still joining us here. We had quite a bit of interest in this webinar and appreciate your participation. We think we've amassed a great slate of briefers for you all, both at the state and local level. We're excited to get going. Again, my name is Jeff Locke. I oversee our corrections support for governor's offices from within our Public Safety and Legal Counsel program at NGA. And since the start of the pandemic, our program has attempted to support our nation's governors and their staffers as they rise to meet this crisis, both overall and with respect to folks who are incarcerated and the correctional officers and others involved in the justice system working alongside them. We've attempted to do this by emphasizing correctional settings as a major point of emphasis for governor's offices. We've attempted to provide technical assistance through a series of memoranda and hosting numerous private briefing calls specifically for our key audiences who are governor's criminal justice policy advisors, state public safety executives, single agency leaders, and governor's legal counsel. This work has in part addressed infection mitigation in all phases of the criminal justice system, from policing to pretrial detention to incarceration, as well as community supervision and reentry. Over the last 9 months, we brought together state officials and subject matter experts to provide governors and their staff with up-to-the-minute strategies for responding to that particular stage of the pandemic within the contours of the justice system. Today, this public-facing webinar is an opportunity to learn from leaders in the field around strategies to prevent the spread of coronavirus, underscore the importance of corrections writ large, both corrections officers and individuals who are incarcerated or detained, and better assist state efforts to save lives in and out of correctional settings as we head into 2021. Looking ahead, the next phase of our support for governor's offices will focus on vaccine administration in correctional settings. If any of the participants on the line have vaccination plans for correctional settings that they'd like to share with NGA, please feel free to email them to my colleague David Engelman, DENGLEMAN@nga.org. Thank you very much for your participation this afternoon. With that, I'll turn it back to David Engelman on my team to kick things off. David?
Thanks, Jeff. My name is David Engelman, and I am a policy analyst in the Public Safety and Legal Counsel program at the National Governors Association. First, a few housekeeping items. This webinar is being recorded, and the recording will be posted on NGA's website at nga.org/webinars. Everyone has been muted to minimize background noise. We're holding all questions until the end of the webinar. If you want to ask a question or participate in the discussion, please select the mute or unmute button at the bottom of your screen or dial *6 if you've joined us by phone. If you experience technical difficulties, please contact my colleague Carl Amrit via the chat or at camritt@nga.org. His email is on the screen. Today's webinar will cover infection control mitigation strategies in correctional settings. Our speakers will discuss the unique challenges infectious diseases pose at all stages of the criminal justice system. And finally, our speakers will identify lessons learned, success stories, and promising strategies state and local governments can adopt to respond to these challenges and protect justice system involved individuals and correctional staff. We have a fantastic group of speakers who have agreed to join the call today and share their perspectives. In this order, we will be hearing from them. We have Dr. Brent Gibson, Managing Director, and Jim Martin, Vice President, Program Development at the National Commission on Correctional Healthcare. Then we'll hear from Dr. Bruce Western, Professor of Sociology and Social Justice and Co-Director of the Justice Lab at Columbia University, and Dr. Emily Wong, Associate Professor of Medicine at Yale School of Medicine, on behalf of the National Academies of Sciences, Engineering, and Medicine. And finally, we will hear from Thomas Abt, Director of the National Commission on COVID-19 and Criminal Justice and Senior Fellow at the Council on Criminal Justice. We will follow the presentations with a question and answer period. I want to thank all of our speakers for being with us today. I'm so excited to hear from these experts, and I'm sure you all are too. So let's get started. Our first speakers come to us from the National Commission on Correctional Healthcare. Brent Gibson is a broadly experienced board-certified physician with over a decade of senior leadership experience in both not-for-profit and for-profit business, with 12 years of public health leadership experience and 16 years of service as a licensed physician. Brent currently serves as Chief Health Officer for the National Commission on Correctional Healthcare and Managing Director of NCCHS Resources, Inc. As the organization's senior clinical executive and a certified association executive, he works in both a leadership and technical capacity and is deeply engaged in defining the overall strategy and direction of the organization. Brent also serves as managing director for the subsidiary not-for-profit consulting firm NCCHS Resources, Inc. He and his entrepreneurial team have provided critical technical assistance to correctional healthcare programs nationwide. He is frequently invited to speak and present at national forums and has contributed over 105 professional publications and appearances to the field. And Jim Martin has served more than 22 years in law enforcement as an assistant jail commander with the Vanderburgh County Sheriff's Office. He served patrol as a canine handler, as a supervisor in the jail, the court security unit, and the professional standards unit. His duties included serving as the command staff liaison for the jail's medical unit and community mental health task force. Jim oversaw implementation of the electronic jail management system, the move to an electronic kiosk system, and a transition to video visitation. He established a state-approved jail officer training school and FTO program. He is now VP of Program Development for NCCHC. He speaks nationally on topics covering correctional healthcare, mental health issues in our jails, de-escalation for healthcare, and building relationships between custody and healthcare. In 2020, he assisted the corrections field in providing COVID-19 updates and served AGA in developing future pandemic response plans in jails. Dr. Gibson, Jim, please take it away.
Thank you very much, David. And on behalf of all of us at NCCHC, we appreciate the opportunity to serve our governors. Dr. Gibson's going to start us off today in talking about some of the lessons that we've learned during a nationally produced roundtable with our sheriffs from across the country, with the major county sheriffs of America. So if we see on our first slide, we'll address some of the things that we're dealing with in the pandemic, and I'll invite Dr. Gibson to talk about those slides as we go through this.
Thanks, Jim.
Dr. Gibson.
Yep, thank you very much. Really excited to be here, and it's a great honor to speak to this group. I think we're ready for our first slide after this one. Excellent. So, you know, pandemic response is this period has been really important and interesting, if you will, to observe. It's very hard to be a disinterested party. There is no such thing in the middle of a pandemic, but we've had to, for the first time in memory as a society and as a culture, had to grapple with pandemic management. From our perspective, both in the correctional health sphere and in some of my sort of previous work with the military, pandemic response is something that's kind of bread and butter to preventive medicine, to occupational medicine, and to public health. And so the steps you'll see here are the things that we would talk about for an effective response. But I have to emphasize many of these things, while they may be second nature in a sort of a controlled environment, such as a military unit, a large hospital, or a jail, they're not sort of commonly understood by, say, the population. And so getting that all put together has been really where some of the challenges are. So if you look across the slide here, and again, many thanks to Jim for these excellent slides, you'll see some things which sound obvious but can be challenging to implement. Look at the first one, for example, limiting visitors to the facility. Well, to someone who's incarcerated, interaction with the outside is important. You don't get much of it. And so the opportunity to see friends or family members or even attorneys is sort of an expectation, and a reasonable one at that. But limiting those interactions is sort of the first step to pandemic control, as we're all sort of familiar with right now. A disease spreads from person to person. So if you reduce that contact, direct or indirect, you reduce or eliminate the chance for infection or transmission, I should say. Moving now to posting visual alerts. Again, we've all been around the businesses in our communities where there's various alerts about you must wear a mask, wash your hands, stay 6 feet apart or 10 feet apart. Those kind of reminders, even if we know it, just being reminded like a stop sign when we're driving is really, really important. So just having the message out there one time isn't really enough. There's also been a lot of conversation about the lack of availability, if you will, for basic supplies for infection control, things like tissues, hand sanitizer, soap even. I'm sure there are correctional facilities out there where that is maybe not as distributed as we would expect, but honestly, these are basic things that you really should find in any correctional facility. In our experience, they are. And do keep in mind, though, as an organization, we really accredit a small fraction of the nation's facilities, both jails and prisons. And so we can't really speak to things where we haven't been. But when we go into a facility, when we do accreditation, these are basic things we look for. Now, the other thing, if you'll be right, we're kind of right in the middle of the graphic here, take steps to prevent known or suspected patients from exposing other patients. This is the sort of quarantine versus isolation. And a very minor sort of technical point, quarantine is when you really don't know what's going on, but you're going to put a group of people or an individual kind of together so that if they have been exposed, they're going to be less likely to spread it. It's an old Navy term when a ship would come into dock from a foreign place with unknown disease risk, you would put them in the harbor for 40 days quarantine. And so 40 days is not recommended for this particular disease, but that's where the term comes from. Once you have a confirmed infection or you're highly suspicious, you can then isolate that person, as we know, and just as you would for any other disease. And that's where I want to remind us that we've been dealing with tuberculosis as a very nasty respiratory infection for many decades and centuries, really. And our jails in particular are very, very adept at how to manage these sorts of patients who can appear at any time. And so negative pressure rooms are something that Jim and I have been looking at and inspecting, if you will, for a very long time. Limiting movements of infected patients, again, it's sort of one of those things that sounds obvious, but remember, in a jail or in a prison, going to inmate movement, if you will, going about the business. Most people may not know this, but in an incarcerated setting, very few people actually don't move around. Almost a great majority of the people who are incarcerated, they have jobs or other duties, and they're mixing and mingling on a regular basis, both with each other and with staff, both correctional officers and any other number of people who are in the jail. So limiting the movement of infected or potentially infected people is really essentially. The other thing you can do, which I think you've seen in civilian settings, is identifying dedicated staff to care for infected patients. That's kind of a tough one. And it may be an easier process with the vaccine now catching on. You would prefer to have a person taking care of infected folks who themselves is at a much lower risk for infection. In other words, who's been vaccinated or previously exposed in some way. That's a very complicated technical area that we can't really get into, but just think about it that way. And then the final slide, which is unfortunately in my screen just off. Okay, so when you have somebody, we've used the term arrestee here, you could replace that with another term if you want, but when somebody's come in just off the street, that's a high risk area for everything medical because you don't know anything about them. You don't know what substances they've been exposed to. You don't know if they've got injuries, and you don't know their status in terms of what they've been infected with or not. And so that's really the time to sort of start that quarantine process where you're looking for respiratory symptoms. These are generalizations. COVID-19 is something we're learning about every day. We don't have a great handle on asymptomatic transmission, for example, but these are some good general rules to go by. Why don't we go to the next slide, please? Looking ahead, I always caution against the silver bullet. We're going to get this vaccine and then we are finished with pandemic for the rest of the world and forever. It's just not the case. There are going to be outbreaks. There are going to be diseases. There's going to be things that happen like this. It's just the history of infectious disease. So take this opportunity to learn from our sort of collective challenges and mistakes, if you will, and plan for the next outbreak. And here are some simple points I think that they can do. Designate that education, risk communication, all of that is very important. Anybody that has a Facebook news feed will see all of the information, good, bad, and ugly, that's floating around out there. You want to take the opportunity as leaders to sort of try to get to the key information that people need to hear and that's actually true, and educate based on that. You want to explore, moving to the upper right now, explore alternatives to face-to-face triage and visits. And again, moving down to the left, look at personal protective equipment. Nobody would have ever thought in the land of plenty we would run out of simple things like face masks, but these things are in demand. It's been only recently that it's readily available, these simple, inexpensive protective measures. So plan on keeping that stuff available. And then you always want to have a plan for triage and management of patients. Mass casualty drills, for example, are something you want to have as a part of your repertoire. Mass casualty doesn't mean a plane crash all the time. It could mean that, or an earthquake. It could mean what we're having right now. Just because you're not immediately critically ill doesn't mean it's not a mass casualty. If you've got a triage, 200 people that have just been arrested of unknown health, you've got to be prepared to do that and then know where you're going to put them. Let's go to our next slide, please. Here are some considerations that I think we've touched on throughout the first, sort of our opening comments. Always be prepared for a potential surge in patients. Now, I would say, coming from the military, our capacity was always worst case scenario. We have giant hospitals that were largely, may or may not have been used at their capacity. We maintain buildings and infrastructure going back to the Second World War, truthfully, in my career. That's one kind of approach to how to handle healthcare. That's the military approach, that always on the verge of disaster, mass casualties. The civilian world doesn't work like that. And one of the challenges I think our healthcare system has seen is hospitals are run very lean. They're run to accommodate the patient demand. Well, the patient demand is not typically at a baseline like a pandemic. So suddenly we're out of ICU space. Again, land of plenty, don't have enough hospital beds, don't have enough ventilators. Very, very sad things, but understandable things. So in the correction side, you do have the opportunity to plan for a mass disaster, whatever it may be. And that includes all the things you can see here that we've touched on earlier, so that you're not caught flat-footed. It's really better to be prepared to have excess capacity than to not have enough. Let me sort of wrap it up here and pass to my colleague, Jim, for our next slide.
Thank you, Dr. Gibson. And it's always nice to be reminded about the public health aspects of it, because correctional health care is indeed public health care. And out of the abundance of time that we have here left, I just want to recognize that, the Council on COVID-19, the National Commission that dealt with the COVID-19, releasing their report, I just want to steal from some of their initial recommendations, is that our goal should be to preserve public health, to get the facts, to be proactive, and improve the equity and increased inclusion. Wonderful tips to show that some of these already exist in our national standards for correctional health care, because they equate so much more to what we're seeing out in our community healthcare. These facilities deal with these kind of pivot as you go every day, because it's no different than the uniqueness of the environment that they're operating in. On this slide, I just wanted to point out a couple that, our standards and how they already affect what we're doing, making sure that our health professionals have that autonomy to be able to make decisions that will affect patient care. Infection, disease, and prevention control has never been more important than it is today. The emergency services response plan, Dr. Gibson just mentioned about practice those. This is a perfect example of a disruption of services and facilities. And I can tell you from personal experience, if you don't practice those plans when the emergency hits, as it did in my facility, you won't be prepared. And how much better we were because we practiced it. Continuity and coordination of care is so important, not only while you're in the facility, but as you are returning them to the communities that they will return to. It is important to make sure we're setting them up for success, to make sure that the rate of recidivism doesn't continue to fill our jails and prisons. And finally, discharge planning, how important it is to connect them with the opportunities that they have out in their community. So if we go to the next slide, you'll see some of the things that we've wanted to try to explain to our inmate population. They're going out, many of them are going out into a community that they don't recognize when they came in. And so because of that, we want to make sure that not only are we telling them how to make connections with their probation or parole officers, but also how to access information on the current pandemic that we're dealing with, the stay-at-home orders, the masks orders, any times that they can be in and out of areas. Every day, it seems like our governors, and rightfully and thankfully so, are giving updates to their constituents to make sure that they know what the current guidelines and standards are for their communities. So on to the next slide, we'll also talk about some of the basic things like making sure that they take their transition into their communities seriously, and that they understand and are educated on what COVID-19 is, looking at programs that they can integrate any of their education, and that our discharge planners are doing such a great job. I'm fortunate to visit many of these facilities, and they're going above and beyond to make sure that they are aware of what's going on in their community. And then simple things like how to properly wash your hands, how to look for those hand sanitizers, how it is important to wear those masks and where they can and can't go into in their community. So that really, as we find, kind of wrap things up here, correctional healthcare is public healthcare. And as some of our presenters today will talk about decarceration and limiting the number of people that are in our facilities, agree with it, don't agree with it, it doesn't matter. But if you are going to release people out into the communities, make sure that we're doing smartly. So that last slide will kind of kind of reiterate what we're trying to convey. If we can see that. These are the things that you need to take an account for. I'm going to let Dr. Gibson wrap it up with the continuity of care for those chronic care patients, but individuals that are leaving custody that might have pre-existing conditions going into an environment they're not comfortable with, do it smartly. We want to make sure that when we're releasing people back into the community that they're being taken care of. And Dr. Gibson, if you can just talk to us about that risk inmate population or going back into the community, and then be happy to pass it on to our next presenters.
Thanks so much, Jim. And I'll just be very brief here. And I think that this, this pandemic is a reminder of the key role that our nation's jails and prisons play in the public health infrastructure. There is a question that's floated around. I'll briefly address it. And that is, what do you do if you have a 2-shot sequence and you get the first one when you're inside and the second one needs to be given when you're released? That's a great question. It's one that hasn't been answered, but it's not unlike the things we deal with all the time when the mental health patients, for example, are discharged on complex antipsychotic regimens. How do you assure that continuity in the community? That is where I think our governors and to some extent the local communities have to just take a sort of a leadership role in protecting the public health and remembering that these patients, whether they're incarcerated or not, they are patients. A lot of talk has been made about decarceration and so forth, and we don't have a position as an organization in that. We are here to assure high healthcare quality, whoever it is that is locked up, if you will, and that's really kind of the lesson learned here. The pandemic has been a giant stress test on our healthcare system, both incarcerated and civilian, and I think we've honestly come through it. I mean, hasn't been great, but on the correctional side, we've come through it very well. In many cases, our jails were, islands of no infection or very limited infection when the things were really sort of on fire out in the community. But final take-home point, remember that jails are not islands. They, despite what I just said, you have this constant flow of people in and out. Staff, healthcare staff, contractor, and jails in particular, inmates are released all the time. And therefore, it's a great opportunity for public health intervention. So we'll stop there and back to the moderators.
Thank you both. And before we move on, I do just want to flag that if any folks have questions that arise, you can either use the Q&A function or the chat box function, and we will ask those on your behalf at the end of our presentations. Our next speakers come to us on behalf of the National Academies of Sciences, Engineering, and Medicine. Dr. Emily Wong is an associate professor in the Yale School of Medicine, director of the SEICHE Center for Health and Justice, director of the Health Justice Lab, and co-founder of the Transitions Clinic Network. She leads these initiatives with a focus on identifying and applying strategies to improve the health of individuals and communities impacted by incarceration. Bruce Western is the Bryce Professor of Sociology and Social Justice and co-director of the Justice Lab at Columbia University. His research has examined the causes, scope, and consequences of the historic growth in U.S. prison populations. His current projects include a randomized experiment assessing the effects of criminal justice fines and fees on misdemeanor defendants in Oklahoma City, and a field study of solitary confinement in Pennsylvania state prisons. Western is also the principal investigator of the Square One project that aims to reimagine the public policy response to violence under conditions of poverty and racial inequality. He was the vice chair of the National Academy of Sciences panel on the causes and consequences of high incarceration rates in the United States. He is the author of Homeward, Life in the Year After Prison, Russell Sage Foundation 2018, and Punishment and Inequality in America, also from Russell Sage in 2006. He is a member of the National Academy of Sciences and the American Academy of Arts and Sciences. He has been a Guggenheim Fellow, a Russell Sage Foundation Visiting Scholar, and a Fellow of the Radcliffe Institute of Advanced Study. Western received his PhD in sociology from the University of California, Los Angeles, and was born in Canberra, Australia. Dr. Western and Dr. Wong, you're up.
Great. Thank you very much, David and Jeff, and thanks to the NGA for inviting us and hosting this session. And so we're going to use our time to report on a National Academy of Sciences, Engineering, Medicine consensus panel study that was specifically looking at decarceration as a strategy for mitigating the spread of COVID-19, both inside facilities and in surrounding communities. Next slide. I want to begin by acknowledging the support for this work from Arnold Ventures and Robert Wood Johnson. Next slide. A nascent consensus panel study brings together a group of leading scholars and practitioners to work on a national policy problem. So in addition to myself, I'm a sociologist, and Emily, who's a physician, we had a large group of people on the team that included physicians, epidemiologists, legal scholars, public policy scholars, and policy practitioners who were working on criminal justice reform problems, as well as in corrections. Next slide. So the statement of task that we were given really focused on two questions, and the committee came together towards the end of the summer of this year, and we were convened in a context in which CDC had just issued guidelines for correctional settings, and it largely focused on the best practices to control the transmission of the virus inside prisons and jails. And it was in this context that a statement of task was formulated that focused on two main questions. One is, what is the role of reducing prison populations, decarcerating prison and jail populations as a COVID-19 mitigation strategy? And when we say mitigation, we're thinking both about the transmission of the virus inside and in surrounding communities. And as we address the question of the role of decarceration, what are the implications too for health equity? The second big question is, if decarceration is indeed a useful strategy for mitigating the spread of the virus, what sorts of supports are needed on the community side in order to do this safely and best address the needs of public health? And so there's this two-pronged charge that the committee was given. We met for a couple of months, surveyed the scientific research in the field. It's a tremendously dynamic field, as you might imagine, because the facts on the ground were shifting very, very quickly and continue to do so. Before I turn to the recommendations, I want to mention 3 findings that we made just quickly. The first one is that according to the best evidence that we have, the measured COVID case rates inside correctional facilities are very, very high compared to in the general population in communities. Looking at data at the beginning of September, about 9% of the prison population had tested positive for COVID. About 5% of correctional staff had, and at that time this was compared to about 1% or so as a positive COVID case rate in the general community. So inside, according to the best measures that we have in state and federal prison facilities, the COVID case rate was about 9 times higher than in the community. The second finding we made was that conditions of incarceration often greatly accelerated the spread of the environment. And the report discusses a number of conditions, and Brent spoke to those as well in his remarks. Population turnover through the facility, and that includes both staff and as well as incarcerated people. The physical design of facilities, a lot of prisons are old. They can be poorly ventilated. Some facilities with dormitory style housing units, it's very, very difficult with that style of housing to control the transmission of the virus. And of course, in a number of facilities and a number of systems, there's also significant overcrowding. And in overcrowded facilities, it's very difficult to follow guidelines around physical distancing, quarantining and cohorting that's recommended as important strategies for mitigating the spread of the virus. The third main finding, I think, is that this is a population in very poor health. And so very high rates of asthma and heart disease, for example, both of which are significant comorbidities for serious complications from COVID-19. And the prison population has been aging as well, which is another significant risk factor. So all of that is by way of context for the recommendations. And if we go to the next slide, we made recommendations in 3 main areas. The first is, what are things we can do immediately? When is decarceration called for? What other strategies does it need to be buttressed by in order to do it effectively? We made a number of recommendations around pandemic preparedness in the future. And finally, there are recommendations around data transparency and research. One thing I'd flag here is that we need to know a lot more about the transmission of infectious disease in general and COVID specifically from the facility to the community. That's the empirical research base there is very thin, and we need to know more. Next slide. So for this audience, where we're thinking about the importance of state policy, something that came up very early in the work of the panel were the challenges that correctional leaders were facing that they reported to us around options for release for medical criteria. In Pennsylvania, for example, where Secretary John Wetzel is from, in order for you to be released under the compassionate release statute in that jurisdiction, you had to be within 6 months of death and non-ambulatory. And those sorts of terms are very common for compassionate release statutes around the country. Makes it very, very difficult to weigh medical vulnerability as a criterion for release. It's too restrictive, and something that we were hearing from correctional leaders was the importance of a compassionate release policy that allowed the consideration of medical vulnerability as a criterion for release. And Bureau of Prisons, I think, at the moment provides a decent model for medical vulnerability as a release criterion in a compassionate release framework. Next slide. And so and Emily will speak more to the recommendations around decarceration, but in our work, it seemed to us to be unambiguously important, and Jim and Brent spoke to this as well, that a policy of population reduction inside has to be complemented with robust supports on the outside as well. And in the context of the pandemic, we think that three things are paramount. There has to be healthcare on the outside, and particularly for people who need it, and that includes not just people who have tested positive for COVID at release, but people with chronic conditions and comorbidities, and needs to be healthcare for them. Continuity of healthcare is fundamentally important there. But the other two things that we saw as really important were housing and housing security. It's very difficult to follow guidance on isolation out in the community in the absence of housing security, in the absence of being able to be housed in private households. And then finally, income support. There's very, very deep material hardship at the moment among formerly incarcerated people immediately after incarceration, that increases their exposure to congregate settings and so on. And in the pandemic environment, that's very challenging. And so I'll hand it off now to my colleague and co-chair, Emily Wong.
Great, thank you so much. I will, kind of put a cap on this, which I think is really important, is that as a committee, we felt that decarceration was an essential and important tool to mitigating COVID within correctional facilities, and specifically found that by depopulating could create opportunities for single celling, for further mitigation strategies. So the conditions that Brent described and those that Bruce also just described were sometimes untenable for a single correctional facility to mitigate an outbreak within a correctional system or prevent it. And so decarceration was critical. Equally important are these this bundle of services, and we were very clear in indicating that there were bundles of services that were important, that would support decarceration, and we've also discussed kind of whether or not these would be deal breakers, really hard to do, and provide examples within our report of states that have taken on the policies that we describe here of thinking about healthcare services, housing, and income supports during our pandemic times, and have been able to help provide these support services, including rapidly housing individuals, including the transition of necessary healthcare services. So it's not untenable to provide these services even during a pandemic. Next slide. The part that was important for correctional facilities, especially thinking about this dynamic between correctional facilities and also the communities in which they reside, was the importance of coordination. And you'll see this as a pressing theme in our report with public health authorities. So thinking about the communities to which people return, especially the families, and especially those that are returning to communities that have already been placed at increased risk, Black and Brown communities, how it is that we can protect families and communities upon return, and given that decarceration is important. And for this, what we did say explicitly was that testing prior to release was a critical piece of decarceration, getting the results back in time so that we could make adequate safety plans for, again, the families, communities, and the individual that's returning home, and facilitating quarantine in the community for 14 days. So in concert, having a testing plan, having a healthcare plan, a housing plan, especially quarantine, and then income supports were critical for that decarceration process. And this is with a larger lens towards health equity. What does health equity look like for us in the time of COVID? Next slide. When thinking about these supports, we also saw that it wasn't just the services that were delivered, there were policies that could be implemented that would really facilitate the services that were needed. And just to give you an example, and we're giving you some of the recommendations that we lay out in the consensus report, is the one around Medicaid. Again, for this group, we thought that that would be a good place. So we identified a number of different ways that Medicaid, either removing barriers or kind of expanding the abilities of Medicaid, could ensure that incarcerated and previously incarcerated individuals could have COVID tests, related services, and especially translational healthcare needs. For thinking about Medicaid, there were opportunities, again, when we wrote this was more salient for those states that hadn't expanded Medicaid under the Affordable Care Act. There was this optional eligibility of Families First Coronavirus Response Act, which would provide Medicaid coverage. And again, I think that that's off the table. The year has ended. But there were certain areas that I think were important within Medicaid. Next slide. In particular, for the states to consider, certain states have already submitted Section 1115 and 1135 waivers of the Social Security Act to expand Medicaid coverage and support. And essentially, these would cover services for incarcerated people during COVID. So testing and delivery of care, hospitalizations, monitoring. States like Illinois, New York, California, Kentucky even have all submitted waivers. And these are ways of, again, supporting kind of testing prior to discharge, to, even the transition of care. So again, you can imagine that for those that have had COVID or those that have concerns of healthcare needs as they transition home, even as we're amidst an opioid overdose epidemic, how it is that you transition substance use treatment, chronic disease management. Medicaid provides kind of an additional buffer during the COVID epidemic to make sure that we're not worsening other conditions. And then also important is making certain that we're suspending and not terminating Medicaid while people are incarcerated. Next slide. Bruce alluded to the fact that, what was clear in our deliberations and looking at the data that exist is as follows, is that it has not been a consistent way of understanding how it is that COVID-19 has impacted correctional facilities, from states, prison systems, to local jails, to ICE detention centers, to juvenile facilities. And I'll put this, which is in contrast to what's existing within your long-term care facilities and nursing homes, where CMS in April indicated a certain set of measures that ought to be reported, that you could follow, track, and better understand what was going on within those hot spots of COVID. Within correctional facilities, there was not consistent guidance, and thus really disparate reporting across states, jails, juvenile facilities, and ICE detention. And so again, we set forward recommendations here, which are kind of no-brainers, but should happen. A report of daily standardized aggregate data on incidence, testing rate, hospitalizations, mortality, and all-cause mortality, and split thinking about incarcerated people and staff by age, gender, race, ethnicity. This is how you know what's going on in your state. It should be public facing. Public health officials should be able to see it, share it, and immediately act upon it so that you can manage ongoing outbreaks now, currently in the states, and forward thinking, in future pandemics. I'm always reminded we're in an interpandemic period when you're not even in a pandemic. These are important things to have in place. Next slide. In that vein, one thing that was apparent to us also is that, in looking at past pandemics in correctional facilities, it's not a surprise that COVID-19 has hit correctional facilities. These have been and are currently hotspots of especially respiratory outbreaks. And one place that has been important in the past literature as well as now is the integration of public health officials into correctional facilities, and also having preparedness planning that involves public health experts, medical experts, and correctional officials in the creation of health plans. And this includes explicit planning on decarceration, how it is that you get people home safely and in a safer place during a pandemic. Next slide. This was not part of our consensus report. Again, we were focused on decarceration, but given the opportunity, I think it really does highlight our point. And again, it was part of the introduction. Bruce and I and other centers in the country have been working on really trying to shine a light of the importance of putting a lens on public health within corrections. And here what we have is a map where we've displayed, again, from December 15. So these are constantly changing, the interim plans for vaccine distribution. And you can see in the green here are the states that have placed incarcerated individuals in the highest priority population. Again, what we've indicated and what we found in our consensus report is that certainly because they're hotspots of infections, correctional facilities ought to be in the highest priority population, incarcerated people as well as staff. And you can see the state maps are all over the place. Some people on phase 2, phase 3, not included. And for us, what this is also just a telltale sign is that public health officials, correctional officials ought to be working collectively at the state level within your state advisory vaccine committees. There ought to be all these individuals at the table. So correctional facilities, justice involved individuals discussing the plans for vaccines that centers vaccine distribution where people are most at risk, which is correctional facilities. Next slide. And so if there are kind of some final thoughts within our consensus report, one of the things that we want to highlight is that public safety, there's nothing that tells us that now, except that when we're in the time of a pandemic, really encompasses good public health. That these institutions of incarceration, as I mentioned in the past and then currently, have been the places of outbreaks and pose a threat to our public safety. And so we have to think about decarceration as an effective strategy. If fewer people inside means fewer outbreaks. The second is that good health and safety during COVID-19 will require reducing incarceration populations and then supporting those communities where incarceration rates are the highest. And so again, a lens towards those who are incarcerated, those who work there, as well as their families and communities to which they return. And then lastly, to really successfully execute kind of a decarceration strategy, it requires urgent, sustained engagement from correctional and health officials at your state levels, and especially having deep partnership at the state level, whereby community health systems and social services are in collaboration, in communication with correctional health systems. Next slide. I think that's it. So here's where you can download a copy of our report.
Thank you both so much. Our final speaker comes to us from the Council on Criminal Justice. Thomas Abt is a senior fellow with the Council on Criminal Justice, where he directs the National Commission on COVID-19 and Criminal Justice. In addition, Abt teaches, studies, and writes about the use of evidence-informed approaches to reduce urban violence. He is the author of Bleeding Out: The Devastating Consequences of Urban Violence and a Bold New Plan for Peace in the Streets. And his work has been featured in major media outlets, including The Atlantic, The Economist, Foreign Affairs, The New Yorker, The New York Times, The Wall Street Journal, CNN, MSNBC, PBS, and National Public Radio. Prior to the council, Abt served as a senior fellow at the Harvard Kennedy and law schools. Before Harvard, Abt served as Deputy Secretary for Public Safety to Governor Andrew Cuomo in New York, where he oversaw all criminal justice and homeland security agencies. Before New York, Abt served as Chief of Staff to the Office of Justice Programs at the U.S. Department of Justice. Abt received a bachelor's degree in economics from the University of Michigan and a law degree with honors from the Georgetown University Law Center. Thomas, the floor is yours.
Thank you, David, and thank you, NGA. It's a pleasure to be with all of you, and I look forward to presenting the recommendations of the National Commission on COVID-19 and Criminal Justice. I'll just say at the outset that some of what I'm about to tell you may sound repetitive from previous presentations, and I think that's a good thing. And what it suggests is that there's consensus among public safety and public health officials on what is the right and wrong choices for public safety policymakers moving forward. Next slide, please. So first, a bit about the Council on Criminal Justice. It was launched in July of 2019, and it's an invitational membership organization and think tank serving as a center of gravity for policy and leadership in the criminal justice field. The goal of the Council is to advance understanding of the criminal justice policy choices that face the nation through nonpartisan research and consensus-based task forces. Next slide. The Commission on COVID-19 and Criminal Justice is one of these task forces. It was launched in July of this year, and it will conclude its work by the end of this year. It's led by former Attorneys General Loretta Lynch and Alberto Gonzalez, along with a diverse set of leaders from policing, courts, corrections, community-based organizations, academia, and public health. Next slide. Here are our members, and as you'll see, these members come from different parties, different sectors of the criminal justice system, represent different constituencies. The approach here is nonpartisan, or at least bipartisan. We have a big city mayor, we have a former and current police chief, we have 2 attorneys general, former, of course. We have a public health expert in Tom Inglesby, a sheriff, and others. Next slide, please. You can see we also have prominent advocates or an activist, Desmond Meade from the Florida Rights Restoration Coalition and Pastor Michael McBride. We have a judge, a prosecutor, a defense attorney, as well as an academic, and of course, a director of corrections of a state system. Next slide, please. So those are the members. What's the mission of the National Commission on COVID-19 and Criminal Justice? Well, there's a threefold purpose of the commission. The first is to assess the impact of COVID-19 on the criminal justice system and on criminal justice involved populations. The second is to develop priority prevention strategies to minimize the impact of a resurgence of COVID-19 or future pandemics, essentially to stop the spread of the virus. And third is to establish a priority agenda looking forward for policy and practice based on the Commission's work. Next slide. I'm pleased to report that the Commission has done exactly what it was supposed to do. In terms of assessing the impact of the coronavirus pandemic, we've produced a number of impact reports, several of which have been updated recently to reflect recent data on crime trends, jail case and death rates, prison case and death rates, issues of domestic violence, substance abuse, racial disparities, and we co-released a report with Johns Hopkins on public health and prisons. In addition, on October 1st, we released our interim recommendations that set out 33 concrete steps to stop the spread of COVID-19 right now. And finally, released just this Monday on December 14th, we released our final recommendations, which are really forward-looking and examine what a post-pandemic criminal justice system should look like. And that's going to be the majority of my presentation with you today. So just noting in contrast to other presentations today, this is involving the entire criminal justice system, police, corrections, courts, and community-based organizations. Next slide. So first, a little bit from our interim recommendations. And I urge all of you to go on our website, which I hope we can place in the chat, to look at both the interim report and the final report. A few of the key recommendations of those 33 steps that we set out were: number one, recognize that the virus, if uncontained, grows exponentially and not in a linear function. So that means you have to be hyper vigilant and and very proactive in terms of getting ahead of the virus. And so we recommend that when you look at official guidance from the CDC, WHO, or anywhere else, that you really look at that as a floor, not a ceiling for your actions. Second, we adopted a strong universal masking requirement for all staff and justice involved populations when indoors and in close contact with others. Despite the political controversy, the science is in. Universal masking works. It works to reduce, although not eliminate, the spread of COVID-19. So it's an essential aspect of policies in terms of containing the spread. We also believe that criminal justice agencies should be widely and frequently testing staff and justice-involved populations using the most reliable methods available. We stopped short of mass testing because I don't think there's unanimity in the field about mass testing, but we definitely urge policymakers to go beyond the testing of just symptomatic individuals. You must be testing asymptomatic individuals as well if you want to stay consistent with recommendation 1, which is getting ahead of the virus by being proactive. Next slide, please. Wherever possible, criminal justice agencies have to limit contact, maximize distance, and reduce density. And you heard much of this discussion in from our last presentation. And I should just note that the Commission was heavily influenced by the National Academy of Sciences report. And in fact, we shared a member. And so we drew on their authority and expertise in many respects. And so here's just a short list of ways we recommended limiting contact, maximizing distance, and reducing density. Making arrests only when necessary to protect the public, reducing in-court appearances, reducing admissions, increasing releases, and crucially, engaging community-based organizations to help maintain public safety. And I'll talk more about that in a few minutes. Lastly, as we know, the legitimacy of the criminal justice system is being examined now more than ever, and so it is absolutely critical to actively engage and consider impacted communities in all decision making. Next slide. Now let's turn to the final report and look at what we found and ultimately what we recommended. Our first major finding was not surprising, and you've already heard it here from other presenters. Criminal justice agencies simply were not prepared for a large-scale public health crisis like the coronavirus pandemic. As Dr. Gibson mentioned, every correctional facility, every law enforcement agency engages in some form of emergency planning. But those plans largely did not contemplate the circumstances with which we were faced this year. So not surprisingly, a key recommendation, similar to the National Academy's recommendation, is to engage all of the sectors of the system, as well as public health authorities and community-based organizations, in integrated crisis response plans. And that doesn't mean simply putting words on a page. That means doing tabletop exercises, engaging in live simulations, and really doing role-playing exercises in order to be sure that when faced with a crisis, people know their roles and know their responsibilities. In addition, we recommended prioritizing those incarcerated and working within the system for early access to vaccines and PPE. Specifically, we recommended that everyone with direct contact with the public or with correctional populations be priority access, priority level 1B under the CDC guidelines. And that includes those incarcerated in jails and prisons for the very same reasons articulated by Dr. Wong. We believe that we need to establish standing coordinating panels for public health emergency preparedness. And importantly, we need to build community-based capacity to support justice-involved populations. This panel this commission is perhaps the first of its kind to really recognize community-based organizations as a co-equal branch of the criminal justice system. And our informal shorthand was COPS, courts, corrections, and community-based organizations. And so one of the things that we call for is really expanding the capacity of these organizations. Again and again, we heard testimony of community-based organizations stepping up and providing public health guidance, particularly to highly impacted and often disconnected populations. The repurposing of street outreach workers to deliver public health guidance on masking and other guidelines. And this community-based capacity is essential if in times of crisis we need to decarcerate quickly. And so this is an important component and an unusual component of our recommendations. Next slide. This is a graph indicating jail populations contrasted with the rolling 7-day average of COVID cases. And what you can see here is that at the beginning of the pandemic, there was a significant drop in jail populations, approximately 31%. But then those jail populations have been slowly but steadily increasing back upwards as the pandemic has gone on. And one of the things that you can also see is that those slow increases are completely unrelated to spikes in COVID cases. And so while there was an initial response, we are no longer really responding to the infection case and death rates moving forward. And so that's something we believe people need to be wary of. Next slide. And this really fits with our second finding and recommendation, that the scale and scope of the criminal justice, just its sheer size, along with the absence of effective public health coordination, posed an obstacle to COVID-19 control. And so we recommend rebalancing criminal justice and public health responses in order to, again, limit contact, maximize distance, and reduce density. We set out everything from emergency release mechanisms along the lines suggested by the national academies, but we also talked about investing in evidence-based public health alternatives to traditional law enforcement, particularly for issues such as mental health or drug addiction. We also recommended ensuring adequate access to behavioral health treatment, adequate medical care, and stable housing for those returning from incarceration. Next slide, please. Here you have a graphic that is looking at the confirmed COVID-19 cases as a fraction of population. And so what you can see here is, if you look at SD, which stands for South Dakota at the top, that the statewide, there is approximately 8 to 9% of the entire population has a confirmed COVID-19 infection. But on the incarceration side, it's over 50%. And what we did here is, this is a 50-state analysis, but we just took the top 10 and bottom 10. And the point here is to really show that as a hallmark of our decentralized criminal justice system, there is just a wide distance between the top performers and the bottom performers in terms of responding to COVID-19. There are 14 state correctional systems which have death rates that are lower than their rates in their communities, but there are 5 states where the death rates are more than 7 times higher than the community rates. So in response to this, next slide, we issued finding and recommendation 3. We found that inconsistency and wide variation among criminal justice agencies impeded the response to a pandemic that doesn't recognize jurisdictional boundaries. And so we encourage the adoption of shared standards and best practices for responding to public health emergencies, like the coronavirus pandemic. And these standards and practices included issuing citations in lieu of arrests, identifying which court proceedings were appropriate for video conference, and mandating national basic standards of care for correctional healthcare operations. We heard a great presentation early on from Dr. Gibson and Mr. Martin, but note that those are voluntary standards and they don't cover all correctional facilities. And so that's something I hope we can talk about in the Q&A. Next slide. This finding and recommendation I won't spend much time on because it's already been discussed by Drs. Western and Wong. But in a modern criminal justice system, data is not some abstract academic exercise. It's not something for wonks and nerds. Data is now the lifeblood of modern criminal justice administration. And if you don't have that data, you're really flying blind. And it's even more important when you're responding to a public health crisis like the coronavirus pandemic. So we absolutely believe that agencies should report on case testing, positivity, hospitalization, and mortality rates, but it's also very important to include demographic characteristics. We looked hard at whether responses to COVID-19 were exacerbating racial disparities in the criminal justice system. And we were frustrated because we couldn't say much on that subject. And one of the reasons was the limitations in the data. And so, we can't manage what we don't measure. And so we need to make sure that we have those demographic characteristics in there. We should also document changes in practice, and federal research agencies should support this effort by developing a new data architecture and supporting it with funding, as well as training and technical assistance, and funding a national research agenda on COVID-19 in the criminal justice system. Next slide. Our fifth and final recommendation concerned communication. We heard some quite harrowing stories in testimony from officials, from people who had been incarcerated during the pandemic, corrections officers, and family members about the fear, mistrust, and confusion caused by the lack of communication and transparency, particularly in correctional facilities, but also throughout the criminal justice system generally. And so we believe that you must improve communication and increase transparency by developing reliable channels of communication. We need to establish liaisons in criminal justice agencies for precisely this purpose. We need to do a better job, in particular, in correctional facilities, connecting people in custody with their families and counsel. And finally, we need to partner with and equip community-based organizations to engage the most vulnerable and disconnected populations. Community-based organizations, particularly those with the relationships with these impacted these impacted populations who have been disproportionately impacted by crime, by the criminal justice system, and now finally by COVID-19. We need to reach out to these communities, and these CBOs can be a critical difference maker. And so with that, I'll conclude. Thank you very much.
Thank you, Thomas, and thank you to all of our speakers for their presentations and the tremendous work that they're each doing in this area. So for the remainder of our time together, about 19 minutes, we're going to do question and answer. If you'd like to ask a question, please submit it through either the Q&A function or the chat box. And we've already got one question this way, and then we've also got some prepared questions and questions registrants submitted in advance. I know that Dr. Gibson got us started answering the initial question that was provided in the Q&A, but I did want to return to this for all of our panelists. Given the given short stays and high turnover in correctional settings, there are these logistical challenges that are naturally going to arise when administering a 2-dose vaccine. Do any of our panelists have some guidance on how how correctional facilities can manage the process of a successful handoff to make sure that people get their second doses if their first was administered, or vice versa, if they received one dose of the vaccine before being detained or incarcerated and then now need their second one.
So I'll go ahead and take that on. I think this is a kind of, again, puts a real fine point on this issue of the siloing of the healthcare system behind bars. That, in so many domains, if it's testing and then here again in vaccines, correctional facilities are often left on their own, jails and prisons alike, to kind of manage, and without coordination and oversight from federal public health agencies at the state level, as well as coordination with the health systems, it's virtually impossible kind of to do the job at hand. And so, I would say our consensus report really highlighted the need for interactions, ongoing, structured, hopefully in a committee or state. We didn't articulate exactly what that would look like, but, with vaccines, it's in these state advisory committees that have been convened by the governors, where there could even be a correctional subcommittee that's really looking at how it is that you bring the right health systems, public health providers, correctional leaders, and then, again, justice involved individuals to talk about what it looks like to implement a preparedness plan, and in this case, vaccines and vaccine distribution from corrections post-release. Within my own primary care practice, I work in Transitions Clinic Network, where I'm a primary care provider for people that return home from prison. And, just to give you the example, and what I know best is from Connecticut, we have been working closely with correctional facilities, with our local, the Connecticut Coalition to End Homelessness, and also our health department, of thinking about how it is that you provide that bundle of services so that no person is released from corrections without a plan back into the community to get their next vaccine. That's important, just not only for vaccine distribution, but it's also important for, again, their opioid use disorder, diabetes. And so it is the need for to end the practice of siloing correctional health systems. And again, thinking about rural jails in South Dakota, for instance, how is it that you transition those people that are moving in and out of the jail system? You have to have coordinated care, and it has to come, I think, with some sort of state or kind of government oversight around that coordination.
Thank you for that. Any other perspectives on this topic? Well, we got a couple of questions from registrants when they signed up for this webinar that I'd like to ask. The first one, and this one is also sort of a toss-up for all our panelists, is what are your most important lessons learned in the COVID-19 response for corrections? What would sort of be the thing that you didn't expect, or that you've been surprised by throughout this process that you'd like folks to be aware of?
I can start there, and this is true for corrections systems, but also across the systems. We weren't able to do a scientific report, establishing a causal link between certain practices and others. But really, what came across as we examined higher performers versus lower performers, states that seem to be doing better versus states that seem to be doing worse, is that there really wasn't a silver bullet out there, and that there wasn't sort of, one single strategy, and that it really appeared to be a matter of perspiration over inspiration. The agencies and jurisdictions and states that ultimately seemed to be more successful sort of got started earlier, devoted more time and energy and resources, and then, very importantly, remained vigilant. Because as we've seen, you can think you have the virus under control, only have an outbreak, and then have it start spiraling out of control again.
Thanks, Thomas. Dr. Western, I see you raising your hand. Go ahead.
I think it's a great question, and I think what was really striking for me, and I've been working on criminal justice policy for decades now, and something I learned very quickly, and this will seem naive, I'm sure, to Brent and Jim and Emily and Thomas as well, perhaps, was just the utter separation of correctional healthcare from the rest of the US healthcare system. And it means at least two things. It means that correctional healthcare was left out significantly of pandemic preparedness planning very early in the year, early in 2020, when the pandemic was still looming on the horizon. And the other thing is that, our safety net systems, particularly thinking about Medicaid, which is just absolutely pivotal in pandemic response now in the rest of the community. The way our safety net systems are shut out of prisons and jails, the way coverage is terminated or suspended, makes a unified public health strategy extremely challenging. And that was a very fast lesson for me in working on the committee.
Thanks, Dr. Western. Anything from our friends at NCCHC on what sort of took you by surprise in this process?
Thank you, David. Yeah, part was resiliency, part were those who were prepared versus those who were not. And I think Thomas made a great point that, our national standards that are out there are a voluntary document. And to truly measure whether or not you are found into being in compliance with those is to be measured through things like accreditation, through certifications. I think one of the greatest things was just the education piece of it. When we were doing the roundtables with the major county sheriffs of America and with National Sheriff's Association, American Jail Association, all those in the correctional healthcare realm, they were doing their best to stay in front of it, the best that they can. Some were better prepared than others. Some saw this coming and went ahead and got that personal protective equipment. They spoke with their local community health departments. They coordinated discharge planning. They did all the things that our esteemed panelists here recommend that we do. Others buried their head in the sand, didn't believe that this was going to be the pandemic that we've seen it to be. And it's not just from our community leaders, but just the perception of our communities. It's just such a division on what you believe to be true or not true. One of the things that struck me was how some of the facilities turn to their behavioral health specialists as well, because you're already in an environment of corrections that's unusual at best. It's its own little environment. And then you have people who are experiencing behavioral health issues. And then you start throwing in the fact that, now everyone's wearing masks in the facility, and what's the message that's being portrayed. And those that were successful communicated that to the inmate population. The facilities that I saw that were really successful in being proactive were talking to their inmate populations and educating them, explaining why it was, offering the services that they could. There are a lot of recommendations that came out of our discussions, and we try to do the best to facilitate those for all those, and almost like a menu type, pick and choose what your facility can be. So resiliency is always great, and we learn from these things. Some were better prepared because they had done those tabletops, had those disaster plans that weren't just on paper, but they were practicing them. A lot of us, this is the same thing we saw with tuberculosis, with HIV, with Hep C. We have dealt with those. And as a jail commander, I can tell you nothing spreads faster than head lice and bed bugs. And so, adapting those to the pandemic that you're doing right now, it's very similar if you just stop, you think about it, and coordinate with your healthcare. And as Emily said, get out of those silos.
I would add one more thing to that. I mean, I do think, well, there certainly is truth to that. I mean, it's just not a surprise that there have been kind of past outbreaks, head lice, bed bugs, et cetera. I mean, these are congregate settings where many people live. I mean, I think one thing that is, we've never lived through a pandemic, but, I talked to kind of ID specialists, once we're out of this, we're going to be in an interpandemic time. There's always something looming, and it'll always be corrections that will be at the fore. And what's more, I mean, if history tells us that's the case, right? There are new things. You can't just apply what you knew from H1N1. And so, what was surprising to me, I have to say, at the state level is that when we looked at the decarceration rates in committee, between January and June, the rates went down about 11% nationwide, right? But jails were really accounting for most of that. It's like 22%, if I'm remembering correctly. And then state prisons were at around 5%. And in part, and that surprised me, even in states where governors were saying, we need to decarcerate, we want an executive order, let's do it. We don't have a mechanism at the state level that's agile enough to be able to do it. We don't have a mechanism at the state level to say, hey, we should be able to convene this committee right now. This is a new pandemic. Let's do it. These people need to be at the table for corrections. And, as someone that's been practicing for 12, I only take care of people that are returned home from prison. All my time is spent thinking about the health of people that come home. That really surprised me that, if our governors can't do it, who can? We don't have the systems to do it. And so, for me, this is going to happen again. We know this to be true, and so what systems can we put in place that will actually enable us to be better prepared so that there isn't that discrepancy, that Thomas showed, that there aren't prisons and jails that are really placing their individuals and their workers at such high risk, that we can convene the groups that we need quickly to accommodate for new pandemics, because they're always going to come.
Well, I think that's a great way to pivot to sort of this balancing act between the sort of steady state year over year sort of preparedness and resiliency type work, and then also the way in which in the local context of an individual pandemic with its unique dynamics and its novel circumstances, what sort of advice do folks on the panel have about things that could have been done better in terms of communicating new information as it was developed and developing strategies in real time in response to new research and new information that we were getting about the way this worked? This sort of ties into a type of question that we got from one of our registrants about, the development of national protocols and guidelines and the sort of best in class information for infection control that is specific to the pandemic we're dealing with right now. I know that one thing that we've heard about that was kind of surprising, and I don't know if this resonates with any of the experience of the panelists, was that certain folks were finding it more helpful to rely upon CDC guidance as it related to congregate facilities than to correctional facilities in particular, and that there are sometimes these disconnects in terms of the work and experience on the ground, along with what has actually been tested, and you can't, you don't have the time always to test these things as you go. So what are the ways that we can make sure that the response is more nimble and more finely tuned to the individual circumstances of a given pandemic?
Well, I mean, I think that the elephant in the room, and I don't want to be excessively political, is really the absence of federal leadership during the coronavirus pandemic. And that's a general point. But it was also specific to criminal justice. I'll be candid. The council is a non-governmental organization, and we're nonpartisan. And perhaps we had the prestige and resources to do this work. But that commission should have been led by the federal government and not by a non-governmental organization. And so we were entering a void. And in the future, a more rapid response for a pandemic that spans boundaries like this needs to have stronger leadership at the federal level in all regards. And so I think that's going to be an important point moving forward. The other thing I think that was unfortunate was the politicalization of information. And one of the things that we saw from even our very commission members was not being sure which information to trust. And the lack of confidence in the federal government on its guidelines, I think really hampered our overall response.
Thanks, Thomas. Dr. Western, yeah.
Yeah, I think Thomas makes a good point, and I'd only add to it by saying that, and we talked about this a lot in our panel, is that an advisory board, I think, would need to be, and maybe there needs to be standing forums, because as Emily said, we're in one of two states. We're either in a pandemic or between pandemics, and an advisory board needs to include at least both criminal justice expertise and health and medical expertise as well, and both forms of expertise and not always convened together. And yet the institution stands right at the intersection of health policy and criminal justice policy. And I'd also add, it's imperative, I think, to have the voices of the people that are most affected by what's going on represented and on such advisory boards as well.
Thanks, Dr. Western. We're short on time here, but I did, out of respect to our registrants and their time, I did want to ask this one last question we got from the Q&A. This is from Adesua Watson. Some community members were not in favor of decarceration during this pandemic and felt that, quote, those folks did not deserve care and consideration, including some elected officials. What is a shared message to share with folks, elected officials and victims, that what is done is for the health of all?
I can just briefly speak to this, and the point is to, and I apologize, I've got a bit of an overlap here, so I'm sorry for any noise you might hear. So the key is to think about these folks incarcerated as patients rather than what is their legal status. And when you make decisions based on that, as well as how those people integrate into the community, it becomes a little more clear. Because there are lots of congregate settings out there, and there were not calls, for example, to turn people out of nursing homes and all kinds of other stuff. So there's a bit of a sort of back and forth and pushing and shoving about what we're actually trying to accomplish here. So I think tailoring the messaging to be genuine and to focus on the healthcare aspects of it is how we make good decisions. For example, in one of the counties we work with, there was all of a sudden, the incarcerated population was now a homeless population that had to be housed. And that brought with it all the challenges, that you might think. So again, just focusing on the healthcare of the community as a whole, including the incarcerated population, I think can be really useful.
Well, thanks, everyone. Dr. Gibson, Jim, Dr. Wong, Dr. Western, and Thomas, thank you all so much for giving us some of your valuable time. If anyone would like to ask any follow-up questions by email, please feel free to contact me at dengleman@nga.org. This marks the end of today's webinar and of our webinar series on equity and policy preparedness during public health emergencies. A recording of today's webinar will be posted along with others in the webinar series at www.nga.org/webinars. Thank you again to our speakers and audience for their participation. Enjoy the rest of your day.